Hello, Kidney Warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live. Now, for those of you that are joining us for the very first time, welcome. It is great to have you here. You're going to learn a lot of information. We're packed with professionals, positivity, and helpful stuff that it's hard to find other places, and we make it easy to understand. Now, if you are new, let me quickly introduce myself. My name is James. About 2.5 years ago, I spent a week in the ICU, and I was diagnosed with kidney failure. Oh, it was something scary. But I have not gone on dialysis. I have not gotten a transplant. I focused on my overall health, eating better, getting my blood pressure under control, getting my blood sugar looking much, much better, saying goodbye to the Twinkies, goodbye to McDonald's, bye Miss Wendy's, all them. And as I've improved my overall health, so have my labs. But more importantly, I feel great. I got rid of anemia. All the symptoms I was suffering, gone. And I am so excited. Now, my kidneys, they're still shot. They're not doing great. I'm just not overburdening them. Trying to kind of live in a nice little balance where I'm not asking too much of them and they're keeping up with me. Now, tonight, we've got an interesting topic, something that as I'm starting to get a little bit older, and I hate to say that, but yeah, as I'm approaching an older age, I started thinking, hey, what am I going to do when I retire? I'm not there yet, but when I do retire, how am I going to pay for things? Your kidneys naturally decline as you get older, and with mine where they are, there's a good chance that unless that artificial kidney gets developed in the next decade or so, I may in the future need dialysis or a transplant. And I started wondering about Medicare. Now, one person who came to mind when I started thinking about Medicare is Dr. Qasim Butt down in Texas. Let's go ahead and welcome him real quick because he has been here before and we've talked about Medicare and how to get things covered. And we're going to talk about that tonight. So if you've got questions, make sure and post them in the comments. He loves answering your questions. And that also shows you this is a live show. So let's go ahead and let's welcome him. Hey there, doctor. How you doing?
How's it going, James? How's it going? It's been about a month now, right? So how you been?
Hey, I've been great. So actually, let me share a little bit. I've become more active as the weather's starting to get warmer. I went out and I got me an awesome bike, and it had the teeniest, tiniest little seat, which did not work for me because I got a big old butt. So then I went and I got this big old comfortable seat. It was better, but not perfect. And then, did you know they sell padded bikers underwear?
Wow. Honestly, so one of the big reasons I haven't taken up bicycling is I'm not wearing those shorts, man. I am not wearing those shorts.
Oh, they have underwear that go under your pants that are padded. So with those and the big old giant thick cushions, and it's a wide seat. It's made for extra cushioned people. I am out there getting active, riding a bike, got my daughter a bike, and we're doing it together, which is fantastic. So trying to drop that COVID weight that I put on the last year or so.
Everyone's got to get rid of that COVID 15, right? They got to bring that 15 down to 10.
The COVID 50? Is that what you said? Now, for those that are new, go ahead and tell them about yourself and how they can follow you on your YouTube channel.
Yeah, man. So I'm Dr. Qasim Butt. I'm an interventional nephrologist, a kidney doctor in San Antonio, Texas. I've been practicing for over 10 years. I'm pretty active on social media. I do health-related content. I try to make it fun and quick. My videos are typically 2 to 5 minutes long, but I make it fun, interactive, easy to understand using simple language. You can follow me on YouTube at Your Kidneys, Your Health, but on any other platform at Qasim Butt MD. I'm on Facebook, LinkedIn, YouTube, and Instagram, Twitter too, but not so much. But if you want to engage with me there, it'd be great, and follow me, and that's it, man. And so that's who I am.
Yep. And about how long have you been working in the field of nephrology?
I've been over 10 years, man. I've been I'm going on 11, no probation, man. So like I've been at it for a while now, man. So yeah, and if you count my training, that's another that's 15, 16 years. So I've been at it for a while now. You get sick of kidneys after a while. I'm just kidding, y'all. I'm not sick of kidneys. But
I'm kind of sick of having kidney disease too. It'd be nice to just be able to turn it off.
Yeah. Well, I have to hear y'all's problems, so it's like
yeah, and for those of you that are new, we like to put a little bit of humor in it. We both have our own little style because living with kidney disease, it kind of sucks. But if you can add a little bit of humor to it, some of it you can't change, some of it you can, and we can make it livable.
I think we should have a content warning beforehand, like a trigger warning saying, "Hey, must have sense of humor before watching" or something.
Yeah, there you go.
Yeah. Anyway, can I start off with a really cool story before we get into Medicare real quick? Okay, so I know you were talking about getting older, and we were talking earlier that a lot of patients are
slightly older. I'm not there yet.
Slightly older.
Yep.
Older. More aged American, right?
There you go. More aged American.
More cute. All right. So as far I had something happen real cool over the weekend to me. Not to me actually, but for one of my patients. So one of my patients came to me first time, 60-year-old Hispanic guy here in San Antonio. I got him late. His creatinine was really high. GFR was down. I did a kidney biopsy on him. It was really bad diabetic nephropathy, diabetic kidney disease, right? Mm-hmm. So essentially I get that late. That's the common story in America. We get these patients so late, CKD 4 and 5, and then I can't do nothing for you, right?
Yep.
So what I did, I was like talking to him when his GFR hit 20. By the way, you guys, if anybody's CKD 4 or 5, when your GFR hits 20 or less, refer yourself to a transplant center. Okay. So what I did is I referred this dude to a transplant center. Doesn't have any living donors around, nobody family to donate. But his kidney function kept declining. When it kept declining, I actually was about to get him a PD catheter, start PD. Okay, right about to start PD. Then that same weekend, right before he was going to get the PD catheter placed, he gets called from the transplant center for a transplant this Sunday.
Holy cow! I get an
email from his wife saying, "Hey, he's at the hospital. They're going to give him a kidney transplant. He got a kidney transplant this week. Never had to see dialysis. And that's very rare for a 60-year-old.
As soon as you qualify, get on the list.
Get on the list. You can get on multiple lists. In certain states, it's worse. I've heard California, it's like 10 years. Texas, I think 5 to 7, somewhere around there. So every state is a little different. I'm not saying shop around, guys. I'm not saying that. But what I'm saying is if you can get on different lists, that's fine. But you guys have to be active, right? I was aware. I was like, get GFR 20, send them. But some nephrologists may miss it. So you guys have to be active and get that in there. So, but I just wanted to start with a happy story for us.
Yeah, we are our best advocate. And that's one of the things we kind of learn here on Dadvice TV is by learning bits of information, we learn questions to ask and things to help push and remind our nephrologist or our family doctor, if we're working with them, to help make sure that we're getting the best treatment possible. So that is absolutely wonderful. If the time comes that I need on a transplant list, everything in a driving distance, I'm going to be getting on all the lists. And I learned they don't all have the exact same qualifications. And that's another reason I'm really focused, for my heart.
So what's interesting, we talked about this before, by the way. You talk about qualifications. This is fascinating. So remember we talked about the Trump executive order and how that changed kidney health. So I call this the transplant center at this place. A transplant center called me just to inform me. I had found out a few days before because the wife had emailed me. But I was like, yeah, I know. But I was like, dude, how do you get on the list so quickly? Like, how's that possible? And they have told me they may have changed their criteria for what they consider an acceptable kidney. You see what I'm saying? So before they had this ideal kidney, right? This perfect kidney.
It had to be perfect. Yeah.
And so from a cadaver. But now they're saying, okay, if it's a little bit suboptimal, who cares? It saves that person from being on dialysis.
Yes.
So the criteria is changing, and more and more people are going to get transplant. There's massive innovation happening in kidney care as a whole and in transplant as a whole. So they're changing the way they do things, how the what they call organ procurement, how they harvest these organs and treat these organs. So guess what? Guys, you guys stay hopeful and stay on it that, hey, my GFR is 20, doc. Send me to a transplant center. Okay. Make sure you get that referral.
Yeah. Now, if your GFR dips below 20 and then over time, like mine, it got down to 8, then to 13, and then it took a long time to get up to above 20. Do you fall off the And you may not know that. Do I fall off the list?
You don't fall off the list, but yourself, man. So it's different for everybody. So like, a patient came to me today and the GFR is 19, I'd refer him, right?
Yep.
But if it was 21 next time, which is a normal variability of your GFR, right? Can go up and down. Like that's 19% to 21%. That's not too much of an increase. That's not going to kick you off the list. But you were a different story, and I think people out there got to know a different story. That you had probably acute kidney failure on top of chronic kidney failure, and so when you made all those lifestyle changes, and you stopped those you were on NSAIDs too.
Yes, ibuprofen.
All that stuff. You stop that. You give your your kidneys time to heal. So it's a little different, but yeah, I'm not a transplant expert by any means. I'm not trying to be that, but just know when your kidney function hits GFR hits 20, or if you're on dialysis currently, you should know, are you on a transplant or not? And I'm not trying to knock my patients, but some people don't even know if they're on the transplant list. You see what I'm saying? And so it's very important that you guys take that power on yourselves and say, hey, am I on the transplant list? Why not? Can I be? What's the reason? Okay.
Well, yeah, when you're diagnosed, it's just a tsunami of information, and then you're trying to process it, and you're filling out so much paperwork, especially in the United States with our healthcare system. You may think, I'm on a transplant list. I don't know. I filled out a bunch of paper. I saw the word transplant on paper. Yeah. Yeah. So always good to double check.
Always good to double check. So what we're going to talk about? Medicare.
Medicare. So much has changed, so recently with Medicare, and I've been trying to learn about Medicare. I've been trying to learn more about retirement and how to pay for things.
Financial planner. Oh my God.
I'm getting to that point, and I'm like,
you need to have this much saved.
Do I have enough money yet to retire?
Yeah.
I would love to do this full time and travel the country and speak, but it's like, health insurance is that one expensive thing that's like, how do you pay for it? Yeah. And Medicare for kidney disease it treats it differently. Thank goodness, it's a positive for us.
So Medicare treats kidney disease completely different. So in 1972, Richard Nixon signed into law that Medicare, which was just care for the elderly. Remember, getting Medicare is typically an age qualifying insurance, right? Age qualifying, meaning you hit 65 and you get Medicare, right? But in 1972, Nixon actually changed it to where it actually covers 65 and older, but also the diagnosis of ESRD, end-stage kidney disease. So it covers end-stage kidney disease people on dialysis. Does not cover you before, but it does cover you once you're on dialysis. Okay. So,
and that's one point I definitely want to make sure it's clear, because when you read it, it says end-stage renal disease, which we assume is stage 5, but that's not when it kicks in. It's when you get a transplant or are actively on dialysis, correct?
Correct. So dialysis is the qualifier that qualifies you for Medicare. So that's how it is. So again, you don't have to be 65. You can be 40 years old. Okay, you can be 40 years old, 35 years old. Now the thing about Medicare, everyone here has to know, is that Medicare, it requires you to pay in 40 quarters of work. Okay, so you pay your Medicare taxes, your Social Security taxes, all that kind of stuff. In order for you to qualify for Medicare as a whole, you have to pay 10 years worth of salary into it. Do you see what I'm saying, guys? So you have to pay 10 years in. And so if you haven't paid that 10 years in, or if your spouse hasn't paid in, so if you're a stay-at-home wife or stay-at-home dad or whatever, and your spouse hasn't paid that in, then you don't qualify. Do you see what I'm saying? So you actually that's how you qualify, is that you have 10 years or 40 quarters of Medicare payments into the system, then you qualify for Medicare. Okay.
Yeah, and I logged into the Medicare website and I verified that I've met my requirements. It's nice. It tells you clearly you met it. If you are with the Social Security, it lets you know if you paid in enough to where you could qualify for that.
And so that's how you qualify for Medicare, okay? And again, so you can be 40 years old and you get dialysis like yourself, or need dialysis, so not like yourself, but before 65. And
we'll assume I'm 40. I like that part.
Yeah. I'm perpetually 39, or 29, excuse me. So
29 adjacent.
29, so. Yeah. 19 at heart, though. 19 at heart.
There you go.
Anyways, so what we're about to say. But the thing is, so Medicare does pay for dialysis in itself. Now, this is the interesting thing. So this is where I'm going to blow y'all's minds, and I don't want to confuse y'all. Okay, so let's just start with someone that's, say, over 65. Okay, let's just start with someone that's over 65. So when you start with someone who's 65, let's just say, because most of our patients, they're older, right? They're typically older. Their kidney disease declined over time, and they're close to the Medicare age anyway. So let's just say you're a Medicare patient anyway. So your Medicare is just gonna pay for your dialysis as well. But the way Medicare works, remember guys, Medicare is Part A, B, and D. Okay. A covers your hospital admissions. So when you go to the hospital, do all the procedures there, whatever, doctor's payments in the hospital, that's Medicare Part A. That comes to you free at 65. So that's yours, okay? Then you have Medicare Part B, okay? But B actually covers your outpatient procedures. So outpatient surgeries, outpatient procedures, outpatient doctor's visits. Do you see what I'm saying? B is what covers dialysis. Okay, so B covers dialysis. Okay, then you have Part D. D covers medications. Okay, now Part B and Part D have premiums you have to pay to keep going. You see what I'm saying? So to keep in the Medicare system. Oftentimes that can be deducted from your Social Security check or whatever it is. Now, I'm throwing you off for a loop. So remember that Part B is what pays for dialysis, but Part B only pays for 80% of your dialysis. Okay, so you've seen these supplemental insurances that you see, like AARP and all this kind of stuff, like the supplementals. The supplementals kick in to cover that extra 20%. So you have to get a supplemental insurance as well too. So a supplemental insurance will cover the rest of the 20% as well too. So that's how it gets a little complicated. Now, then of course, okay. I feel like I need to do a video on this, James. I need to do a video. I think you do.
And Natalie asked, what happened to C? That's the same thing I'm thinking. Or is that just how the government works? A, B, D. Let's make it confusing.
Yeah. Go to the CMS website. You'll blow your mind. Like, that's crazy.
I tried. That's why I reached out to you.
Medicare
I'm like, hey, let's talk about Medicare.
So then you're talking, then the other plans out there are called Medicare Advantage plans, okay? Medicare Advantage plans are essentially, so I want you to think, I said A, B, and D. Think of that as the Big Mac, fries, and a Coke, okay? We should not be talking about Big Mac, fries, and a Coke on this show, but for the argument's sake, A is the Big Mac, B is the fries, and D is the Coke, okay?
Yep.
Think of Medicare Advantage as the value meal. Okay, Medicare Advantage plans are essentially all of those in one. Okay, so you get A, B, and D in one plan. Okay, I don't think you need a supplement. Yeah, you don't need a supplemental in it either. So
I'm not at 80% on dialysis. I don't need.
No, I don't think so. Medicare Advantage should cover it all. Now the thing is, with Medicare Advantage, it comes with some restrictions. That's why some people don't opt for it. And the reason why is Medicare Advantage is better because it gives you more coverage. It does give you more coverage as far as different things. It includes things like dental and vision. Okay, but it typically puts you in network. So it gives you a certain doctor you can see. You can only see certain doctors. Do you see what I'm saying? So it limits your doctors. Now, can I be honest with you? As a doctor, okay? I think most people would be best suited for Medicare Advantage because it's so encompassing. It takes care of the whole person. It's a lot easier for most people. Now, I think it's personality driven. If you want traditional Medicare, which traditional Medicare is A, B, and D, James, I feel like you're a traditional Medicare guy. And the reason why, you're an intelligent dude, not that anyone else is not intelligent, but you like to read about different doctors, read about different things. You may want different treatments out of network. Do you see what I'm saying?
Yeah.
So a traditional Medicare plan, and I just noticed the complexities that I just showed it to you, right? Like A, B, D, supplemental, all that stuff. Well, guess what? With Medicare, but that gives you the freedom, James, to like, oh, I don't like this doctor in town. I want to go to the other part of town and see that doctor.
So it sounds like it's maybe more like a PPO, and I can see someone else, but maybe if I do that, maybe it costs a little more, like going out of network type thing.
Yeah, I think there'd be out of network kind of things, but that's why a lot of people don't like, some people don't like Medicare Advantage plans. But what I've seen, to be honest with you, man, like most people, especially when they get over 70 and they're just kind of chilling and hanging out, doing their dialysis or whatever in their lives, they don't have that much drive to, find a new doctor, change doctors. Most people don't change doctors or whatever. So, a lot of times I would recommend Medicare Advantage. I don't recommend plans. I just don't do that. But what I'm saying is, for someone who wants a simple, cost-effective solution, Medicare Advantage may be your best deal to get. You see what I'm saying?
Yep. Get it all grouped together. You got your coverage.
One payment. Yeah, it's just easier. So that's how and that's how it is there. So Medicare Advantage is like that, and then you have A, B, and D as those options as well to kind of get it separate if you want as well too. And then. Just so you guys know, sometimes there's issues. And some of y'all may be on dialysis. Sometimes, paying all those premiums, like we talked for B and D, gets expensive, right? And the supplemental and all this kind of stuff gets expensive. If that's the case, they have funds like the American Kidney Fund that kind of help you with paying those bills if you need that kind of help. But you have to have certain income requirements, okay? Now, what I want you guys to know is when you guys start dialysis, okay, whether that be home dialysis, by the way, I want you guys to look for home or in-center dialysis, okay, or in-center dialysis. Guess what? When you start with the dialysis unit, you have all the ancillary support you need. You see doctor, 1 to 4 times a month. You see a nurse almost every time you go into the facility. Every time you go to the facility, you see you have a dietitian.
Yep, they're available.
You have a social worker, guys, a social worker. So all the questions I just posed to you and all this complexity I just said to you guys, and you're confused about it, you go talk to your social worker because she or he can handle all those kind of issues. Okay, so you have that ancillary support, particularly when you're on dialysis. When you're on dialysis, you can actually. You have that person there. And what I have a problem with a lot of dialysis patients and this is not to be rude or anything like that, but I feel like they don't take advantage of the support they have. Do you see what I'm saying?
Oh, yeah. Like I actually have people who reach out to me saying, hey, I'm on dialysis. I want to see a dietitian. What do I do? And they're in the United States and a dietitian's available. And Jen Hernandez helped me with a little bit of a blurb that I send to them. And they didn't realize that. A lot of times they're just there. They're getting their treatment. They're ready to go home when they're done.
Absolutely, yeah.
And they don't realize all the things that are available to help them.
Yeah, absolutely. So I want, if you guys are on dialysis, I want you guys to take advantage of the people that are around you. Like meaning, well, not advantage, excuse me, but advantage in the good sense, meaning I have a dietitian and I have diabetes. What can she do to help me manage my diabetes better? Do you see what I'm saying? So you can ask her about low potassium diets, low phosphorus diets, high protein diets, all that good stuff too. But you have someone there at your beck and call that can actually answer your questions. And a lot of these people, and even like myself, James, like we love engagement, right? We love when someone actually has good questions, not the annoying people that play Dr. Google, but the people that are,
they're like, I saw an ad for this herbal thing I wanted to buy. What do you think of it? What about celery and garlic and all those things?
Apple cider vinegar, essential oil, or whatever, okay, I'm gonna do, go ahead. But at the same time, like, we love engagement. So if you have questions, you can always ask them, okay? And again, when you have when you guys are on dialysis or when you're about to go on dialysis, these case managers are there and they can really, social workers are there and they can really help you out as far as getting these plans. They purposely put you there to help you get these plans, okay? Not meaning help you, but they instruct you. And then you oftentimes have what they call insurance brokers, right? And insurance brokers. So insurance brokers help you get these kind of deals and stuff, and not deals, but Medicare plans, Medicare Advantage, Medicare traditional Medicare, whatever it is. So you can consult a broker as well too and get those plans. But if you have any questions about your insurance, and I always say this to my patients too, James. So even when they're not on dialysis or whoever, I always tell patients, is this affordable? If it's not affordable to you, you can always ask me, say, hey doc, can you get me a cheaper med? You see what I'm saying? Or the insurance doesn't cover it. I hate when I have patients that, I haven't seen, I give them medication and they don't see me for 4 months and say, oh, I couldn't afford it. I'm like, dude, you should have just called. I would have given you a cheaper medication, and so you go 4 months without treatment essentially. So, and so that's the thing. So I want you guys to know that you have power and all you need to do is like literally ask the question, but we need to know what questions to ask. Okay. So again, Medicare covers you for dialysis. That's even before 65. Okay. Now, what's interesting, James, is before 65. Let's just say you're working at your job you're working at strip clubs now, right, James? Oh, I forgot. No.
Exactly. I'm working in the back room.
Yeah. Male
By the back room, I meant where the safe is. I just realized what that sounded like.
Oh my God. This is so inappropriate.
I watched the TV show Good Girls. One of the husbands works in the back room.
Okay. Anyway, I know you did that to pay your way through college, James. But
there we go. It's expensive.
But anyway, so let's just say you work at Hewlett Packard or General Motors or whatever, like whatever company, right? Microsoft. Guess what? When you're working for those companies, you have insurance to them. Let's just say you're 40 years old and you're actually going on dialysis at 40. Guess what? During that time, while you're still working, those first 3 years, your commercial carrier, Blue Cross Blue Shield United, is actually paying for dialysis. Okay, so they're paying for dialysis, but after 30 months of dialysis, that insurance carrier is off the hook and Medicare takes over. You see what I'm saying?
So you still have that while you're working.
Yeah. So you still have it. So you still have it while you're working, and you're working with that. You're still working at the job. And I still encourage a lot of people when they're going dialysis still to work. I really believe work provides encouragement and provides fulfillment to people that other things can't. Right. Especially if you like what you do. Right. But so for the first 30 months, your commercial insurance carrier will actually still pay. And then at 30 months, Medicare kicks in. Okay. And these are things, again, once you're on dialysis, guys, you can actually communicate. With your social worker to make sure that when that 30 months comes up, that the switch is made appropriately to Medicare. You see that? You see what I'm saying?
Yep.
And I remember like there's the open enrollment time, right, which is like October to December. So that's kind of key when you actually do that. So that's how you kind of make that transition whenever you need to. So.
Yeah. Now Olivia has a really good question. We've been talking about if you've worked, you've got your 40 quarter credits, or you're working, maybe Microsoft, and your commercial insurance will cover the dialysis for the first 30 months. What about someone who's not married and hasn't worked and they need dialysis? If they haven't paid in those 40, does Medicare still kick in for that?
No, so at that point, typically what happens is then it goes to the state level, which is Medicaid dollars, right? So Medicaid. So Medicare is for everybody over 65. Medicaid is for the poor, and Medicaid is delineated by the states, right? So if you're in Texas, Texas does it. Ohio does it. Whatever state. I think in California they call it Medi-Cal or something like that. But anyway, so different states allocate it differently, and so at that point you have to qualify by their standards of Medicaid, and so you have to make an application there. Now, dialysis would not be withheld from you. It's not going to be withheld from you, but and I think a lot of the payments are retroactive to the dialysis unit, so that's not going to be a stopper. Do you see what I'm saying?
Yep.
But you just got to make sure you pay into this. If you haven't paid in the system for whatever reason. Now, I've heard like if you're very young, like a 25-year-old that hasn't had time to get that 20 years, it's a different story. Meaning they'll like kind of not retro you in, but what is it?
Grandfather.
Not grandfather. What's the term? Like kind of like say, hey, okay, 5 years you live. They kind of like say, okay, it's okay. You see what I'm saying?
Yeah.
But if you're that person that hasn't paid in the system, I've had people like actually had somebody that actually was like 20 years, he was probably 40 something, but he paid under the table, meaning he never paid taxes. So he never paid taxes at all.
So on paperwork, he never paid in. He never did pay into the system.
Yeah, he never paid in. So he had to go for Medicaid. You see what I'm saying? So everything was like, handyman kind of job or whatever it was. So that kind of stuff happens too. So you do have other insurances called like Medicaid that can kind of help you out as well to pay for dialysis as well too. So. And
that's where a social worker can help you figure out, here's the right option for you.
Absolutely. So this is the thing. Like, again, I know you guys don't know the ins and outs and stuff, right? But let's just say you guys are coming close to dialysis, okay? You're CKD stage 4, a GFR is like 20, 15, but your doctor's telling you, it's coming. why don't you just ask that doctor, hey, do you have a social worker I can talk to at the dialysis unit I'm going to go to? You see what I'm saying? Just to get some advice, right? So we actually have a really cool, what we have is, our practice, we have like a educator, and she educates about like home therapies and PD and home HD and all this cool stuff, right? And when they do that, when in that interaction, and that typically happens when you're stage 4, somewhere around there, you can always ask those questions as well too, and then get in touch with those. We'll get in touch with those, social workers and see what you can do. So if you guys are worried about certain things or how to pay for things or whatever it is, or how Medicare even works, those are options that you can have. And again, this is where you need to have those questions prepared, right? And say, hey, doc, can I you have an educator I can see? Or how's about this? Can I see your social worker at your dialysis unit just to kind of get an idea of what to do? And yeah, that should be easily arrangeable, because typically we have the relationships with those units. So.
Yeah, it's great. You mentioned, preparing your questions. It's great advice for everyone. And I always do it as I'm getting close to an appointment. I'm writing down all the questions, and then I go the extra nerd step. I put them all in Word. I group them by topics, and then I send it to my doctor beforehand, which is great. They love that because they're like, yeah, I know what he's going to ask. I can be prepared. Yeah. And sometimes it'll be like, these questions here, these 3, you don't need to worry about those. And that's good enough for me because I've built a relationship with them and I trust my doctors and my healthcare team that I know if they say, don't worry about that, don't worry about it. Right now, for example, I've seen my, one of the things from triglyceride or the good and the bad, LDL, HDL, whatever it is.
Yeah.
Those are high for me. And I've been like, hey, doc, what do we got to do for that? And he's like, no. We're not worried about that right now. Your uric acid is extremely high. That's what we're getting down. Then we'll go back to those. Don't worry about those right now. Yeah, I'm on some new meds for
I really
the uric
believe in
acid.
Preparing questions, guys. I really do. I really do, guys. Like I tell my patients, write it down before you go there. Don't just think I'll ask him when he gets there, because there's always like 5 or 6 questions, and you may
easy to forget. You get busy.
Easy to forget, and then again, like when you're utilizing us too. When you're utilizing us, like as doctors, think of us as your consultants, right? You're going there for your benefit, right? Like I had to turn to a lady today and go and tell her, I'm not the principal, dude. I'm not the principal. Like, I'm not trying to judge you. I'm not trying to, punish you. When you come to us, think of us as a utility that you can use to make yourself better, right? So what do I got to do, doc, to get my blood pressure under control? What do I got to do to get diabetes? I had that lady come in today and she was like, yeah, and she's lost 20 pounds. And, I was like, losing 20 pounds is probably better than any medication I could ever give you. You see what I'm saying? And so that kind of stuff. And I love that engagement, but you have to be able to utilize your doctor. And if you don't feel like the doctor's engaging or whatever, you're not connecting or not answering your questions, always remember you can switch to another one. You see what I'm saying? So if that happens to you and you don't feel like the doctor connects, and that happens to me too. I'm not saying I'm the perfect doctor. There's people that I have not connected with, don't, rub each other the wrong way or whatever it is. And, they move on or they stay with me, whatever it is. But, it's like you guys have that and you can move on to another doctor, look up another doctor and say, hey, you know what? I'm going to take a look at another doctor and see what happens. So, but yeah.
Yeah. And one of the things you said, which I felt was really important that I learned by doing it wrong, is talk to your doctors, be honest about things.
Oh yeah.
In the beginning, there were symptoms I had that to me were too embarrassing. It's like, I'm not going to talk about that. And I think that delayed my diagnosis of kidney issues. For example, I was peeing, there's blood. I could see it. I think I was passing a stone at the time. I didn't mention that. I'm like, I don't want to go there with that. It's food poisoning, doc. I didn't tell them all my symptoms. And I even get people who message me and they say, hey, what do you think about some recreational thing they may be wanting to take? And I tell them, talk to your doctor. Be honest. They're not there to judge you. They're there to help. Let them know, hey, here's what I'm doing or here's what I want to do, and get their opinion. So you're informed and making a better decision.
And so I prefer the patient that's brutally honest and just says, hey man, I'm not taking the pills. I prefer that because I know where I stand. You know what I'm saying? It's not like I'm going to hate that person, but, just say I'm not taking the pills or forget a lot. Like, so for instance, when I'm managing blood pressure on people, guys, when I'm managing blood pressure, it's very difficult because I have to, sometimes there's 2 or 3 medications on board. Some of them are once a day, some of them are twice a day. I totally get that on your perspective, from your guys' side, that's hard. That's hard to manage. But if you're telling me you're taking it every day and I'm maxed out on those 3 medications, I'm thinking to add a 4th medication. You see what I'm saying? And so if you're not taking it and then I add that 4th medication, you take them all at the same time, you may bottom out your blood pressure. Do you see what I'm saying? So it's always crucial to be honest, even if you're not being honest with your diet. And we talked about this before. I'm big on diet and lifestyle modifications. I'm huge on it. Like I recently had a patient of mine where I just told her, hey girl, just stop the sodas, and her sugars got better. You see what I'm saying? Just like
boom,
that, and yeah. And so,
she did it. My doctor knows. He tells me, don't lie. See, right now I've gained weight. It's obvious. And then when I go in, I get on the scale. He knows right away if I stuck to my diet, and he'll ask me, have you been sticking to your diet or not? And I'm honest. I tell him, no, doc, I'm eating too many carbs. I know it. I'm eating too many carbs. Because if I lie to him, it's not helping anything. And things like that, the diet, he could tell. He knows this should have gotten better. You're not sticking to what I told you.
I mean, guys, consider it like lying to your accountant, right? Like, you can lie to him, but it's eventually going to catch up to you, right? Like, so like, that's how I think of it. Just try to be honest and that's go from there. Can we talk about some of the recent developments in Medicare and how?
Yeah. Because so much has happened.
So recently there's been changes, several things. So one is Medicare Advantage. Before, the way it worked was, let's just say that example I was talking about, you're over 65, let's say you're 70 years old, and you want to choose between Medicare and Medicare Advantage, right? So if you're between Medicare and Medicare Advantage, you can change every year. You can go back and forth. And so you can go back and forth. But if at that time, like say after 65 and you chose you weren't in a Medicare Advantage plan, you were in just a traditional Medicare, and you started dialysis, you could not get into a Medicare Advantage plan. Okay, so if you started dialysis on a traditional Medicare, you are not allowed to switch to Medicare Advantage. Remember, Medicare Advantage is like the value package, right? Dental, vision, all that stuff. And so before, you were not allowed to transfer in and take advantage of being on Medicare Advantage. Now, recently, Medicare has changed those restrictions, and now you can get on Medicare Advantage. So as a dialysis patient, if you're on traditional Medicare right now, you can actually switch to Medicare Advantage if you want, switch out to traditional Medicare and go back and forth if you want. So that was a big development for a lot of people.
Now, one question about Medicare though, is it the same in every state? Where Medicaid is run by the states, Medicare, since it is run by the government, is it the same, or are there certain states that maybe I get better coverage or something?
I can imagine it. The plans vary per company and per area, right? I can imagine those plans could be, like it's not like United is not United of the United States or Blue Cross of the United States, it's Blue Cross Texas, right? So I can imagine there's different plans within them, and you got to remember Medicare oftentimes doesn't run these plans; the insurance carriers do for them, right? So that's what happens there. So what I'm trying to get at is, you can switch back and forth to Medicare Advantage. I am not an advocate for Medicare Advantage. Now, please do not think I'm like pushing you guys to be Medicare Advantage versus say traditional Medicare. I say it depends on your personality and depends on what you want out of it. Okay, James, I'm just looking at you, man. I'm thinking you're traditional Medicare.
Though I'll tell you, I like simplicity. All my bills are auto pay. I would go with the combo one.
The combo one just to get out of the way.
And if I didn't,
dental and vision.
Yeah, and if I didn't like the doctor, I would try to work things out. Right now, I think I've learned so much.
It's not you stuck with the one doctor. It's just within the network or whatever, you know what I'm saying. So
I feel like I've learned so much now that I'm more comfortable with doctors. And I would want to have I'd want one that just communicates. That's just my thing. Let's communicate. Tell me what you're wanting to do, what you want me to do, and let's make it happen.
Yeah, man. So again, I'm not advising it. Please do not go, oh, Dr. Butt told me to get the Medicare Advantage plan. And I'm like, no, man. I'm just saying for simplicity purposes, I think it makes a lot of sense for a lot of people. And so, but again, going back and forth. The other thing was with the other big issue was with Medicare, Medicare as a whole. So Medicare is interesting. So you qualify for Medicare, right? Automatically at 65. If you're on dialysis after 65, you have Medicare anyway. No biggie, right? But before 65, you can get Medicare, right? Now, what's interesting is, so if you're on dialysis, you can get Medicare, Medicare. But let's just say you come off of dialysis, like I've actually taken a recent guy off of dialysis, young guy, 42 years old or something like that. Young guy, I've taken him off. Does he come off of Medicare? Well, guess what? After 12 months of not being on dialysis, you come off of Medicare. So after 12 months, you come off of Medicare. So that's kind of a standard thing. But if, say, I took that guy off not because his kidney function recovered, this guy's kidney function actually recovered, and he was able to come off. But let's just say I got him a kidney transplant, right? And he's 40 years old. Before, Medicare would cover his immunosuppressive medications for about 3 years. Okay. So guess what? Medicare would cover your immunosuppressive. So when you get a transplant, guys, transplants aren't easy. Okay. You're taking an organ from a different person's body, putting it inside you. When you do that, your body has a natural response to want to attack it. Your immune system wants to attack it. So you have to be on immunosuppressive medications, medications to suppress your immune system. Those are crazy expensive. So the first 3 years, post-transplant, Medicare covers those medications, after which they do not. Okay. And that was the game plan there. The reasoning why is because once you get a transplant and you're young, you should get a job, go back to your regular insurance carrier. Do you see what I'm saying? But for some reason, some people don't get it. And what happens is they can't afford their medications and their kidney starts to reject in their bodies and they go back on dialysis.
And
now
we lose that kidney.
So recently they passed a law. I don't know if Biden has signed it yet or something, but they're trying to pass the law where that Medicare will actually continue to cover those transplant medications. You see what I'm saying?
Yeah. So, and I looked to try to see if that was signed yet. I could not tell, but it's going through everything and very excited. All the big kidney organizations have been there pushing to get it approved so they'll be covered for the rest of your life. So we don't risk losing that kidney that someone got just because that expensive medication is outside their budget.
Yeah, and so I think right now what you realize what Medicare is doing, guys, is Medicare is realizing that kidney care and dialysis particularly is extremely expensive. It's extremely expensive. I think I told you before it costs about $80,000-$90,000 a year to keep someone alive in center. So what they're doing is shifting people off of in-center dialysis. They're wanting them to go to home dialysis. They're wanting them to go to get a transplant. So they realize that there's a huge cost savings for them to maintain the transplant medications as opposed to letting that transplant fail and putting that patient back on dialysis. So that's what's going on. CMS is having a CMS, meaning Center for Medicare Medicaid Services. That's why I keep on saying CMS. I don't mean to be with that person that drops all those cool acronyms. But Medicare is realizing, hey, kidney care is too damn expensive, and we need to reallocate how we think of things and how we pay for things to get better results and cheaper and more effective results.
And they also change how they pay people like you so that you are more incentivized to get better results, correct?
Yeah. So what happened, again, was this started with the Trump executive order in 2019. They introduced something called the Kidney Care Choices models. And so these models were actually designed, and I don't want to get into the complexity of them. I actually did a 19-minute video on it. If you guys really are interested in seeing how these models work, I did it for UT Health here, University. I spoke at a conference here, and I actually gave a presentation. If you want to see how they work, that you can watch my video on it. But what they're trying to incentivize is they're changing the payment structure, how I get paid, to incentivize me to get you a kidney transplant and to incentivize me and dialysis units not to do dialysis in the centers, but to do them at home. So that's the two major things they're pushing for at this point. Also, in that mix, they're also pushing for better management of CKD 3, 4s, and 5s, particularly 4s and 5s, but 3s as well. So they want better managers. What they've realized, Medicare's realized, is kidney care, the dialysis itself is so expensive. So trying to adjust costs at this part of the chain, right, at CKD5 and ESRD is stupid. It's just going to be expensive. So it's better to go upstream to CKD4, 3, and 2, not 2, but 3 and 4, and slow the progression down, meaning better management of diabetes, better management of high blood pressure, better education for patients, more awareness, more screening and stuff like that. So they're kind of changing up the whole model here to kind of get us more get us to change our behavior. And so I'm actually really excited about it to see how it goes.
Yeah, and one of the things one of the early takeaways I had after learning so much about kidney disease from a patient point of view is that education, that early education would be critical. I've had high blood pressure for a long time. Never have I had a conversation with my doctor about, if you don't keep your blood pressure under control, if you miss meds or anything like that, you could have kidney problems. Here's what life could be like. None of that was ever a conversation I had. It's kind of like that scared straight tactic. It would have worked for me. I would have been like, okay.
It depends on the person. That's how I say it to people. I'm saying we need to get your diabetes under control, high blood pressure. Because the way I talked to one of my girls today, my patient, she's 48. And I'm like, let's call her Emily. Okay.
There you go.
I was like, hey, you have diabetes and high blood pressure. Today, I'm not talking to 48-year-old Emily. I'm talking to 55-year-old Emily, 60-year-old Emily, and 65-year-old Emily. I want that Emily to be happy and healthy. So if we don't get diabetes and high blood pressure under control, that's what's going to be your outcome there with diabetes meaning strokes, heart attacks, kidney disease are going to be horrible. So that's how I try to address it now.
Yeah, you got people asking, are you taking new patients? You're down in Texas. You're an in-person one.
Yeah, I got someone try to get me on LinkedIn from London, and I'm like, dude, my license is in Texas.
Yeah,
I can't just give advice across the ocean, So it's it's kind of fun, but I appreciate that. I really appreciate that, guys. It's awesome that you guys are asking.
Yep. Let's see. I'm gonna look through here and see if there's any questions that we can answer. Here's one that someone asked. Let's see. Here's someone who's new. We've got a new person, new to kidney disease. So it's a little off topic, but it's about kidney disease. This is a good one. When a person gets diagnosed with CKD, how do you determine that they do have kidney disease? Can you talk about how many tests and what tests they're looking for?
Oh, awesome. Okay, so I've made videos about this. You need to check them. I made videos about kidney function tests and urine tests. So you go check them out. Again, 3 to 5 minutes. It's great. But let me just go over them real quick. So the way you tell you have kidney disease is by a calculation called eGFR, right? And creatinine, right? So creatinine is used as a marker for your kidney function, but that marker is used in the calculation of eGFR. Consider eGFR like a percentage of your kidney function, okay? Normal kidney function is 100%. As we age, it does come down. Now, typically CKD is defined at a GFR of less than 60, typically, okay? But it can be, you can't have CKD if you're above 60 if you have blood or protein in the urine. You see what I'm saying? So if you have blood or protein in the urine at any GFR, you have CKD. If you have no blood or urine in your urine and your GFR is less than 60, you're considered CKD3. Do you see what I'm saying? So that's how we typically do it. Now, to get the most accurate assessment of your eGFR, which is a percentage of kidney function, it's not the eGFR calculation is a blood test. The best way to get the calculation is actually do a 24-hour urine collection, which is called a creatinine clearance. Okay, you collect your urine for 24 hours. You put that in your refrigerator next to your Kool-Aid. I'm just joking, but you can put it in.
But you do refrigerate it, though.
You have to refrigerate. Keep it cold. Keep it cold. Yeah. Don't drink it by accident at night, James.
No.
Do that.
The big thing is do it on the weekend, not during the week when you're going into work.
Well, if everyone's on Zoom meetings now, so you could probably do it while you're in the Zoom meeting.
Yeah, you can do it while you're Zooming.
But in general, yeah. So the most accurate assessment is a 24-hour urine. I don't do 24-hour urines that often, and the reason why that's so cumbersome. And to me, the EGFR calculation is typically pretty accurate. So I use that. So that's what's the definition of CKD. Again, check out my videos if that didn't make sense. It's just they're quick and easy to figure out. So.
Yeah, and for those that are new to CKD, creatinine is not the problem. And as a kidney patient, in the beginning, you're like, they're measuring creatinine to get an estimate of my kidney function. Creatinine must be the problem. That's not the problem. That's just the marker they use to get your estimate.
So let me, if these guys want to hear it, let me just tell them. So creatinine is actually a reflection of your muscle mass. So what it means is when your muscle tissue breaks up, and we do that every day, like all our tissues break up, hair follicles, skin follicles, everything breaks up, right? So and you're including your muscle mass. So your muscle mass is constantly breaking up to some degree. And that muscle mass breakdowns, one of the breakdowns is creatinine, okay? Creatinine. And creatinine, we know we use as a function of, we use as a marker for kidney function because your kidneys actually filter out the creatinine. So the more creatinine they're getting out and less they're having in, that's telling you that the kidneys are working, getting all that creatinine out. And so a normal creatinine on our labs, and again, this is the United States. British labs are different. I know you got some British people here, but is between 0.6 and 1.3. That's a normal serum creatinine. So the higher the creatinine goes to 1.4, 1.5, 1.6, 2, 3, whatever, that's telling you the kidneys aren't cleaning that creatinine out. Do you see what I'm saying? So that's how you know that you have kidney disease. And creatinine is not the problem. Creatinine is not the problem. It's just a reflection of the kidneys not being able to filter and clean it out. That's what's going on.
Yep. And that's it. When I was first diagnosed, I had the mistake of thinking creatinine was a problem. What can I do to reduce creatinine? And it's like, no, that's not the problem. Focus on health. Yeah. That's what we need to focus on.
And you can improve the creatinine, but you're going to be improving your kidney function. So controlling your diabetes, controlling your high blood pressure, getting rid of agents that are hurting your kidneys, like the NSAIDs, those kind of things, losing weight. And losing weight doesn't directly fix the kidneys, but losing weight helps your control your blood pressure and your diabetes. So when I did a video, 5 things you can do.
Good for your heart.
Kidneys. Yeah, good for your heart. But also, remember this too, guys. Kidney disease patients don't die of kidney disease. They die of heart disease, okay? When your kidneys are not working, it causes an inflammatory mechanism in your body. Your body becomes inflamed, and that in itself hurts the heart. And so people with kidney disease die of heart disease, okay? So this is kind of all-encompassing and stuff like that. That's why I always recommend exercise to a lot of people because that losing weight is crucial to getting better kidneys.
Yeah. And here's a question for me from Jane and Bill. They said, James, you look great. Thank you very much. Love the positivity. They've asked, have I had labs and how are my kidneys doing? So it's been a bit of a roller coaster. So it is normal for your creatinine to go up and down, especially when your kidneys are not doing that great. I went about a year without getting labs because of COVID. Got my vaccine shot, my very first one, and that very day I went and I got fresh labs. Results came back. My GFR was down. It was now back into stage 4. Everything looked good except for my LDL, whatever those are. Those were high, and then my uric acid was really bad, and I had been getting some gout symptoms, especially my toes just hurting. So my doctor put me on gout medication, took it for a month, got new labs, back into stage 3. So my GFR, I would say it's stable. It's sitting there in the lower 30s, dipping to 29. It's just kind of doing this, staying in that area. I also was slightly dehydrated when I got my first labs because I knew my weight was going to be up and I didn't want to drink water. You're like, that weighs a lot. I'm going to save a little bit of weight. My uric acid is starting to get lower. It's still high. So we doubled my medication for it. And we will know in about about, I think 3 more weeks or 2.5 more weeks.
Just post it on social media. Post your lab report on social media. That'll be fine. We'll figure it out.
Yeah. I do post them, but I haven't updated them in a long time. But they are out there.
I'm totally
actually.
joking. I was totally joking, dude. But whatever.
I know everyone does that. Mine are on my website. I haven't updated in a while, but now I kind of feel my GFR is stable because it fluctuates normally. And it's staying in this same range. The only symptom I had a problem with was gout. And then the number on the scale being bigger than I want it to be. That I know the cause. That I could take care of. So that's pretty much where I am. I feel good. I'm happy with where things are at. That's not what caused me to start thinking about, Medicaid, dialysis, how am I going to pay for it? I'm starting to plan retirement. I'm like, where am I going to move to live based on my 401k, my investments, my other stuff? I need to start planning it. I'm starting to think in the next 10 years, where do I want to live? Because I've always, since I was young, I wanted to retire early. My original plan when I was young was to retire at 55. I don't think I'm going to make that. I think I'll be pretty close.
Because back when you're young, you think 55 is old. That's why.
Exactly. I was like, 55, I'm too tired. I'm not going to be working.
That's too much.
What I would love to do is do this instead. Travel, encourage people, motivate them. Kind of get more people aware of kidney disease, drive early awareness, early testing, lifestyle, diet changes, things like that. That's kind of, but so that kind of answers the question. I'm back to where I was pretty much, low 30s, feeling great. Mm-hmm. Let's see, we do have another question. We still have a little bit of time. Let's see. This is Abby. She's down in Texas. She's near you. She's going to be showing up one day. I'm saying hi. She wants to know, how do you reduce protein leakage in urine? Do you have any recommendations for that?
Well, mainly like the standard treatment for medication wise is what we call ACEs and ARBs. ACEs and ARBs, ACE inhibitors are end in pril, so lisinopril, enalapril, those medications, and ARBs, which are end in artin. Those are losartan, valsartan, on those kind of medications. Okay, so those are the ones that you want to make sure you're on first place when you talk to your doctor and say, hey, am I on ACE and ARB? And there is a reason why. 2 reasons why you wouldn't be on is, one is people have an allergic reaction, so that would one. The other is if you have constantly high potassium, sometimes your doctor will have to stop those. Okay, so those are 2 medications you should be on. The other thing you can do, you can watch my video on it, but plant-based diets. Plant-based diets are known to actually decrease the amount of protein in the urine, and the reason why is animal protein can actually be deleterious to the glomerulus, which is like the connection to the filter, the little filter in the kidney, the nephron, and so those can actually damage them. So lesser protein diets, lesser animal protein in your diet, that can actually help them as well too. So I would definitely try that as well. And again, I am a big believer in lifestyle modifications, losing weight, guys. Like, I know you guys have kidney disease, I know you have lives and all this stuff, but something as simple as just walking a day. I know how bad the average American diet is. I know how bad the average American lifestyle is. I know y'all ain't walking. I know y'all are sitting there on your couches, especially during COVID. Go out and walk for about a half an hour every day. It's getting warmer everywhere, so go out for a walk. Just walk. If that's the least you can do, okay? For me, not for yourself, just for me, okay?
I love walking, and now I'm trying to get into biking, and I am going 100% into the biking just to get exercise.
And if everyone out there walks, James here is going to wear bicycle shorts on this show for us, and with the padding, with the crotch padding, right?
So let me tell you something. If you go onto Amazon, you look at them, the pants look odd with the built-in stuff. Yeah. One last question before we end, because we're at the top of the hour, and this is a great question because one of my nieces, who has type 1 diabetes. She's adolescent diabetes, and she has some other challenges. Helen asked a great question, and this is something that I was wondering about for my niece. Does thyroid problems affect kidney disease?
Ooh, that's a good one. But yeah, so it depends on how severe your kidneys, your thyroid problems are. So now thyroid problems can mean many things. So I'm going to try to just try to simplify it. So most problems with thyroid are low thyroid, right? Hypothyroidism, where your thyroid function is low. That happens to some of us as we age, but some diseases can cause it too. So low thyroid, if progressed very far, and I've had I remember one patient in particular, his thyroid levels were just so minusculely low that he gained weight, he felt tired, he gained, had all these stressor hormones, everything was off. And so by correcting it, his kidney function actually got better. Weird, right? And there's also something called hyperthyroidism, which is a very rare disorder, but when your thyroid overacts, that has to be treated with ablation or thyroid removal or something like that. That can cause high blood pressure and stuff like that. Now, so the thyroid doesn't necessarily directly affect the kidneys, guys, so it can inadvertently affect the kidneys, but it's not the main culprit here. You see what I'm saying? Of course, I want you guys to have your thyroids under control because you'll feel better, you'll be more at equilibrium or whatever. But directly, no, thyroid does not directly affect the kidneys, but indirectly, yeah, it could,
Very good. All right, let me bring up your YouTube channel name right on there just to remind everybody. Yeah. You've heard a lot of stuff. We've been here for an hour. Dr. Butt makes these awesome short videos on his YouTube channel called Your Kidneys, Your Health. You can also find them on Facebook, and you can go to dadvicetv.com/Dr-Butt, or just go to dadvicetv.com. You'll see him right there on the home page, a picture of him, and you can see all of his visits here on Dadvice TV and all the topics we've talked about. I'd like to thank you, Dr. Butt, for being here and sharing this information. Man. That is great. And hey, Abby, she said she dared me to wear bicycle pants. Okay, so there is a YouTube community on dadvicetv.com. If I can lose, and I can do this, let me lose 50 pounds first. I can do that.
50? Whoa.
Yeah.
50, sir, not 15,
my doctor is
right?
talking triple digits, what he would like. Let me lose 50, and I will take a humorous picture in bicycle pants. Because I suffer from that Dunlop disease. My belly's Dunlopped over my belt, and I want to get rid of that part first. And I'll post it. So you look in the community on YouTube. There's a great community. You can chat with each other. And
do me a favor. Tell me when you make that post or that video on YouTube, because I'm gonna actually get rid of my YouTube app off my phone just to avoid it for a few days.
Then we done scare you.
I don't want to be on my YouTube feed. I want my food in my gut, not out.
Wait, you don't want to say, hey, there's something new. Click here and see it.
Yeah. YouTube follows us, so they know that I love your stuff. So automatically, it's gonna be right at the top of my feed.
There you go.
Yeah.
Big guy in little pants.
Yeah.
All right. Thank you very much, Dr. Butt. And thank you, everyone out there. If you haven't done so yet, hop on over to YouTube and subscribe to dadvicetv.com or to Dadvice TV. I'm used to saying .com on that. And I will see everyone else next week. This is the last video for this week. So have a great week, and I'll see you all in the next video. Bye, everyone.